Today we're going to talk about melanoma surgery. Melanoma skin cancer is the 5th most common cancer in the United States. Melanoma is a skin cancer that comes from the melanin-producing cells called melanocytes. These cells are in the lower layer of the skin and produce a pigment melanin that turns your skin dark. A normal mole is a cluster of non-cancerous melanocytes. Melanoma means that these melanin-producing cells have become cancerous. Melanoma is only 5% of all skin cancers. The other types of skin cancer, such as squamous cell skin cancer and basal cell skin cancer, are much more common but are not as dangerous. These other kinds of skin cancer rarely spread or metastasize and take a long time to grow deep and big. Melanoma, on the other hand, can spread to lymph nodes or metastasize even when smaller than a grain of rice. Most commonly, melanoma occurs on sun-exposed skin. Risk factors for melanoma include having red hair or blonde hair, green or blue eyes, and a history of multiple sunburns. It can happen at any age, even in teenagers and young adults. Most melanoma grow from pre-existing moles. If a mole is changing with A for asymmetric margins, B for borders that are ragged, C for colors that are different or changing, or D, diameter is more than a pencil eraser and growing, then this could be a sign of melanoma. A doctor will biopsy any concerning skin lesions with these characteristics. Common ways of doing a mole biopsy is to use a knife to scoop out the mole, commonly called a shave biopsy, or taking a round piece of skin out with a special device and stitching the hole shut, and this is called a punch biopsy. Once the suspicious mole is biopsied, it is sent to pathology. The pathology doctor needs to tell us if the mole is a cancerous melanoma. And if it is a melanoma, we want to know how deep it is growing down into the skin. This is the most important thing for a surgeon to know about the melanoma. We also want to know if the most superficial layer of skin over the melanoma is gone, which is a factor called ulceration. An ulcerated melanoma may ooze or bleed also. Ulceration of a melanoma is a sign that it is more aggressive, so it's a bad thing. Based on the depth and ulceration, most of the decisions for surgery can be made. The most common form of melanoma is melanoma in situ. In situ means that the melanoma cells are stuck in the most superficial part of the skin and have not spread down into the skin layers. These tend to spread out in the skin and the edges can be very hard to see. Even though the melanoma cells have not grown deep, we still remove the full thickness of skin down to the fat underlying the skin. Melanoma cells also spread out into the skin, and we always want a margin of normal skin around a melanoma to be sure that we also remove these few satellite cells. For melanoma in situ, we need to remove 5 millimeters from the visible edge of the melanoma. I'll draw exact sizes here using a ruler. If the melanoma is about 1 centimeter in size, then taking 5 millimeters in every direction leaves it around a 2 centimeter hole. In order to close a hole in the skin that is 2 centimeters in diameter, we can't just stitch together because the edges will lump up and it just won't look good. Surgeons usually make an ellipse shape that is about 3 times as long as it is wide, and when we stitch this shut, it will be a nice flat line. So for the 2 centimeter in diameter hole, we make a 6 centimeter long elliptical excision. The next form of melanoma is considered invasive down into the skin. If the depth of invasive melanoma is less than 1 millimeter from the surface of the skin, this is called a thin melanoma. Thin melanoma is deeper than in situ melanoma, and so we want an even bigger margin of normal skin around it. For a thin melanoma, we want to go 1 centimeter out from the edge of the visible melanoma in every direction. For a 1 centimeter in diameter melanoma, this means that the excision hole is 3 centimeters in diameter. The ellipse of skin removed to close this in a flat line is then 3 times as long, so 9 centimeters in length. This is about 3.5 inches for you non-metrics out there. Even a 3-inch incision is probably easier to do in an operating room. The next level of melanoma surgery is any melanoma deeper than 1 millimeter in depth. Any melanoma deeper than 1 millimeter and up to 4 millimeters in depth is called an intermediate thickness melanoma. Any melanoma deeper than 4 millimeters in depth is called a thick melanoma. The deeper a melanoma gets, the more dangerous it is as far as the ability to spread or metastasize and regrow. But from a surgeon perspective, we usually treat intermediate and thick melanomas the same. We recommend removing 2 centimeters in every direction from the edge of the melanoma. These holes can get pretty big. For a 1 centimeter in diameter melanoma, a 2 centimeter margin in every direction will result in at least a 5 centimeter hole in diameter. We also recommend removing the entire thickness of the skin and the underlying fat tissue all the way down to the muscle underneath for these melanomas. To close the skin in a straight line for a 5 centimeter in diameter hole, the ellipse will be 15 centimeters long. This is 6 inches in length. This requires that we lift the skin up off of its attachments to the underlying muscle for about 5 to 10 centimeters off to the sides of the cut. This releases the tension so that the edges of the skin can be pulled together with stitches again. This leaves a large pocket under the closure. Also common to discuss skin grafts or skin rearranging flaps with these bigger excisions.
Melanoma can spread to lymph nodes. Lymph nodes are part of your immune system and are attached to channels that lay just under the skin called lymphatic channels that carry lymphatic fluid. Melanoma deeper than 1 millimeter can have cells break off into the lymphatic fluid and get carried to the lymph nodes, where they get stuck and grow. The technique to check the lymph nodes is called a sentinel lymph node biopsy, and I have a separate talk on that you should check out. Anytime we have a melanoma deeper than 1 millimeter, or a thin melanoma that is ulcerated, we consider checking the sentinel lymph node biopsy. To recap lymph node management in melanoma, for thin melanomas that are ulcerated, or any melanoma deeper than 1 millimeter, you should check a sentinel lymph node if you cannot feel melanoma already growing in lymph nodes. If you can feel in large lymph nodes already growing melanoma, then you should remove all of the lymph nodes in that area. If melanoma is found in the sentinel lymph node, not every patient needs to have more lymph nodes removed. This was the result of a clinical trial called the MSLT2 study. This study found that removing additional lymph nodes in patients with melanoma in the sentinel lymph node led to more problems and didn't really seem to improve survival. All right, let's talk about when a medical oncologist needs to be involved. Luckily, the vast majority of melanoma is considered cured after just surgery. So melanoma in situ and thin melanoma less than 1 millimeter in depth are most likely going to be treated with surgery alone. Further treatment of melanoma past surgery involves stimulating the immune system to fight the melanoma, and it's given by medical oncologists who are chemotherapy doctors. Intermediate thickness melanoma between 1 to 4 millimeters in depth without spread to the lymph nodes will be unlikely to need additional therapy, but a medical oncologist can see anyway. Any melanoma with spread to the lymph nodes should be seen by a medical oncologist, and these are likely to need immune therapy. Thick melanoma deeper than 4 millimeters, and certainly thick melanoma with spread to lymph nodes may need immune therapy, and these patients should definitely see a medical oncologist. I hope this helps. Melanoma treatment can get complicated, as you can see. The good news is that major advances have been made in the past 20 years, and we are on pace to make just as many advances in the next 20 years. Don't forget to check out our video on melanoma sentinel lymph node biopsy, and don't forget to subscribe. Take care.